we treat them all usually using the masks, various shapes or sizes. So we have, depending on what type of mask you can use one of these. You can use one of these. They're different. You can use one of these. You can even use one of these.
Oh, that's scary.
This was given to me by one of the students in the last class. And what they did, and this was shown to us actually at a conference I was at last year before last. And it is a mask that you can wear prone or supine. There's actually a double mask, you see? Mm-hmm. Normally we don't bother with this. We don't bother with the posterior, only for certain cancers, but this is a new one that's just come out. And then of course we have the two big ones. This and this one. So this one, as you can see, is a fairly large guy. So we would use this one if we wanted the shoulders to be pushed down. So if we were treating sort of larynx area, thereabouts, and the guy had basically no neck, he was a football player, no neck, and would have to push his shoulders down. So that's what we would do here.
Now, the attachments that are on that one, do they stay with those or so like when you make them for somebody, you keep the attachments on there?
This?
Yeah.
This is actually part of the mask.
Oh, okay.
So what this does is attaches the patient to the bed.
So all of them would have the attachment?
In one way or another. This one, for example, the head base holders upstairs. This one, for example, you have holes here, and this would attach to the bed, and it would go into little holes here, pins here, and we would attach it to the bed that way. So it depends how, in various ways, they attach to the bed. And it helps keep the patient still. So let's just put you back on again here. So this is going to take us a couple of weeks, this head and neck. And while this is coming up, everybody know that the college is closed for President's Day. Does everybody know that?
When's that?
15th, not next week, but the week after. So hopefully we'll have this finished by then. So this is the area we're going to have to cover. So, nasopharynx, oral, so we're counting lip, oral cavity, tongue, floor of mouth, and oropharynx. Then we have the hypopharynx and larynx, paranasal sinuses, and salivary glands. We're going to have to go all through all of these, plus the orbit. So we start, I believe, with the nasopharynx. So the pharynx has 3 portions, if you remember from your anatomy.
Yes.
Oropharynx, laryngopharynx or hypopharynx, and nasopharynx. You have another one?
No,
how I was saying it, and then I was like, oh, maybe I'm wrong. And then you said nasopharynx.
Okay, yeah. So nasopharynx they put first because it is quite common, at least in some places. So we'll do the nasopharynx first, since it comes first in the book, I believe. So incidence, it's not quite common, but if you notice, has anybody read this chapter? No? Okay. So if you look, there are various things that can cause smoking, tobacco, smokeless tobacco, alcohol, marijuana, again, smoking, viruses. So what would be the virus? What virus do you think we're talking about? Nope. Not herpes. Anybody heard of HPV?
No.
Are you on a specific page in the book right now?
Yep.
575.
574-5. So this is the stuff that we're looking at for all of head and neck. So we've got smoking, smokeless tobacco, snuff, or chewing tobacco, marijuana, anything you smoke basically, alcohol. You'll find a lot of people with any of the head and neck cancers are smokers. They're also sometimes heavy drinkers. The HPV ones, also Epstein-Barr. What is Epstein-Barr normally known for? What other disease? Epstein-Barr?
Is that mono?
Pardon?
Is that mono? No.
Yeah, what's the correct name for it?
Mononucleosis?
Mononucleosis, yeah. So marijuana, genetics, of course, which always come in useful. And it says here, dentures, fillings, and poor oral hygiene and diet. So the reason why they put in dentures and fillings is because if you have somebody who does not have well-fitting dentures, the dentures can rub. And it can make it, it can give them a chronic infection. And that, along with poor hygiene, can give them a precancerous disease and finally go on to cancer. So you'll see that I'm turning now to page 577. And you'll see the pharynx. The pharynx. So there's three parts of the pharynx. Nasopharynx, which is just behind the nose, surprisingly enough. The oropharynx, which is around the oral cavity, again, surprisingly enough. And the laryngopharynx, or the hypopharynx, which is around the larynx area. And you can see also the other areas of the body, the tonsils, the hard palate, the soft palate, the uvula, the palatine tonsil, the lingual tonsil, the epiglottis, the hyoid, the vocal cords, the trachea, and the esophagus. So we'll start with the nasopharynx. And we'll come back to the we'll come back to general principles later. Okay, nasopharynx. 2,000 new cases annually. Age group, there's two age groups actually. One which is a younger group, which is anybody from I think 15 to 25, but the majority of them are over 50. Gender, it's mainly male. Race, Southeast Asian. The majority of them are Southeast Asian. We do get Caucasian nasopharynx patients, but the majority of them are Southeast Asian. Chinese, Vietnamese, Laotian, Cambodian, Hong Kong, that area. So worldwide, obviously, as I said, Asia and Chinese immigrants or Southeast Asian immigrants into the country, they tend to fill up our quota of nasopharynx patients. Causes are unknown, but the risk factors are diet, Epstein-Barr virus, and hereditary. Majority of our, I was lucky enough to go on an exchange trip with a group of us when I was in Canada to China. And the city just across from Hong Kong, which used to be called Canton, is now Guangzhou. We went to visit radiation therapy departments in China. And in Guangzhou City, the department we went into, 80% of the patients they treated was nasopharynx. 80% was nasopharynx. It was amazing. And we asked them why. We shouldn't have done that. Because we got a little, but before we left, they gave us all a booklet. And it explained why southern China was more susceptible to nasopharynx. And it turned out that this is diet. It's quite amazing. Vegetables and rice, and it's basically what they use for the properties of the soil that causes the problems. So, symptoms: neck mass, hearing loss, nasal blockage and pain in the late stages. It is very unusual to use surgery to treat nasopharynx. The number one treatment for nasopharynx is radiation therapy. So the types are squamous cell carcinoma, keratinizing squamous cell carcinoma, non-keratinizing carcinoma, undifferentiated carcinoma, and lymphoepithelioma. Majority of the time, it's the squamous cell carcinoma. You can ignore the keratinizing, but squamous cell carcinoma is the most common. And it's most common in all head and neck cancers. Magnetic resonance imaging, MRI, or PET, positron emission tomography. That's what's used for diagnosis. %80 of the patients at diagnosis have got lymphatic spread. And that's why we tend to treat them first rather than try and do surgery. And for the metastasis, the usual suspects, bone, lung, and liver. Surgery is rarely used except to check the nodes. Let me just find the nasopharynx. If you're going to be following along, the nasopharynx starts on page 597, if you want to. So neck dissection, what do we mean by neck dissection? Anybody know? Anybody care to guess? What do we mean by neck dissection?
Removal of some parts of the neck.
A little more specific.
Removing the cancer.
No. Not specifically, no.
Maybe like cutting to see like where it is.
Like exploratory.
If you remember, we said that 80% of patients are node positive. What does that mean?
So they're removing all the lymph nodes in the neck.
So what they're doing is a neck dissection is removal of the nodes in the neck, either all of them or just some of them. So here you have selective, which means that you remove the ones that look abnormal. Modified radical means that you would remove the nodes on the same side as the tumor. And radical means you remove everything, all the nodes. which makes it leaves you with the neck being very abnormal. So the nodes are sitting here and here. If you remove all of those, it completely destroys the shape of the neck. That's why we don't like the surgeons getting a hold of them first. But they do. I asked one of the surgeons at one point, when he was doing a radical neck dissection on a patient with cancer of the floor of mouth, which is here. And they wanted to remove all of the neck nodes here. It's a radical. And I said to him, how do you explain to that patient and his family what he will look like when you remove all of the neck nodes? Think about that. I mean, they're taking all of this away. And he looked at us and said, something we have to do. The patient has to live with it. And I thought, typical surgeon. But yeah, he didn't give me an answer, put it that way. I don't know what he tells the patients, but it's very difficult. So chemo. Most head and neck patients have some kind of chemotherapy while they're having radiation. This is a list of some of them. The first 5 are fairly common. The others are not quite as common. So cisplatin, 5-FU, doxorubicin, ipirubicin, and bleomycin. And you could probably put methotrexate in there as well. But those are the ones, you don't have to remember the names per se, but you have to recognize the name when you see it. Put it that way. So timing. Normally what we do is we treat, the chemo people treat the patient with the chemo, and then we treat them at the same time. So the patient will have had chemo first, and then he come down for treatment, for radiation afterwards. So it's usually a combination of treatments, chemo and radiation. That also, with some of them, it also does a the chemo has an effect on the radiation. What's that called? It has a multiplying effect on the radiation.
Radiosensitive?
Radiosensitive, yeah. Some of these ones are radiosensitizers. So what that means is they help the cells be more sensitive to the radiation. The problem with that is because they're more sensitive, the radiation reaction is more difficult. It is expanded.
So which one of those are radiosensitive?
5-FU, cisplatin, bleomycin.
they factor this in, if they're getting adjuvant care, they would factor this in that they are radiosensitizers.
Say again?
I said if they're getting adjuvant care, would they
Mhm.
factor that in? Knowing that they are radiosensitizers, would they use doxorubicin or?
It depends. They may, the problem is that we may not, the treatment that are being given may be doxorubicin. They may not be using it as a radiosensitizer, but it is a radiosensitizer. So it will enhance the reaction.
No,
They're not using it as a radiosensitizer,
Yes,
but it is one.
But it is one, so because of that, are they factoring that into the treatment plan?
In what way?
Does it alter the actual?
Or is it altering their dose, the amount of dose they're
No,
receiving because of that?
no. The dose that, the radiation dose, no, that doesn't matter. That doesn't, the fact that they're radiosensitizers doesn't factor into the dose. You'll just have an enhanced reaction. So, radiation therapy is a treatment of choice because the nasopharynx is radiosensitive in a way, and we would have, if we need to, the chemo, which is another radiosensitizer, make it even more radiosensitive. The problem is that it can be a very difficult treatment to go through. You're giving chemo, you're putting radiation in, you're giving 6,500 centigrade to the head and neck. The patient has to drink, be able to drink, be able to eat, which sometimes is difficult, sometimes downright impossible. It is a very, very difficult disease to treat. It's one of these things that one of my physician friends said he wouldn't wish on his worst enemy, because it is a very difficult treatment to go through. So the standard head and neck treatment, which is not IMRT. There are two types of treatment. There are 3D treatments or there are IMRT treatments. Normally these days, we would do an IMRT, either static fields, which means you're going to do 7 or 8 fields, or we do a VMAT, which is the arc. However, some physicians still like to do what is called a 3-field technique, which means that if you look on page 597, we are treating the nasopharynx. You can't actually see it here, but we are treating high up. The nasopharynx is opposite the nose, right? So it's about here. We have to go to treat the nose, treat the nasopharynx. We have to go to base of brain, which is here. We have to go all the way down to the supraclavicular fields. So we're treating from here. Now, let's get Fred in. This is Fred, by the way. We got lost at Mardi Gras one year. That's where the beads came from. Come on, Fred. There we go. Okay, so here's Fred. So, nasopharynx. We have to start here, base of brain, and we go all the way down the side. We're doing laterals, all the way down to just above the first rib, here, on both sides. We have to take in the nodes along the spine. So we'll be treating the spine. So what dose? 4,500, yeah. So we treat a rectangle, basically. And then, because we know that the supraclavicular nodes, we treat an anterior supraclavicular field. No. Okay, so we have two fields here, and then one field anteriorly. Stay. And so the field will come down, sorry Fred, the field will come down here, take in this area, all the way down here to the back of the spine. So at 4,500, we have to do something, which means we have to move the treatment, what they call off chord. That's my thing. We have to treat off chord. So, we will, see if I can, Fred, we'll draw that. So, we have this field. And you have the spine, which comes in here. Okay, and where does the spinal cord go in relation to the vertebra? Right down the middle, okay? So you have a cord that runs down, oops, sorry, help it straight, right down the middle. So we have some shielding here and some shielding here because we don't have to treat all of it. And we're treating, there's nodes that run down the side of the cord. So these are lymph nodes. We have to treat those. But we know that we can't go any higher than 4,500, right? So what do? Well, we have what they call an off chord. So this is a lateral, in like this. So what we do is so this is now the area we're treating. However, we still have to treat the nodes. So how do you think we might do that? So we move off chord. We've got this side, and then we reduce to here. So this is the area we're treating. The tumor is somewhere, we'll call it here. And remember, there's nodes all around here. So we've done, this is photons. We're treating this whole area to 4,500. From there, we move off chord, and now we're just treating this area. And this is going to go up to about 5,500. but we know the nodes need more. How do you think we might be able to do that? What type of beam only treats the skin and the subcutaneous tissues?
Superficial?
Pardon?
The superficial?
Superficial, okay, yeah. What other one?
Electron.
Electrons, yes. So what we would do after 4500 is treat this area with electrons. This is why it's not used much anymore. But you have to know it. So this area, we treat with electrons. And the problem is that we have to do a junction between the photon fields, which go from there to here, and the electron fields, which goes from there to here. And remember, the electron fields, they have a bulge in the side, right? Everybody remember that? Okay. So we have to be extremely careful here so we don't overlap. This is one side, the other one is exactly the same. So now for 10 days or so, we would treat both photons and electrons till we get to whatever level the doc wants to do. Then he would say, okay, we've done that. Now we're only going to do a smaller boost. So we'll go here. So just this area is going to be treated. So this area, wherever the lesion is. And we could take that up to almost 7,000 centigrade. Meanwhile, we have another problem. Remember what I said about supraclavicular field? Because we have a field that we want to give, because we know that there's nodes here in the supraclavicular field that might have seeding down into them. So here's the clavicle here, here's the clavicle here. We have a spinal shield that runs down the middle to protect the spine. This is going to be treated to about 5,500. So you've got nodes that run along here. There you go. And then you have a junction as well. So not only do you have a junction here, you have a junction here between the lateral fields and the supraclavicular field. Does that make any sense at all? Oh, good, okay.
Now, since those nodes around the supraclavicular field are away from the spinal cord, if we can treat those with photons?
Yes, yeah, because we're shielding, this is a spinal shield, which is shielding the cervical spine. So we don't have to worry about that, but we don't have to, we can only do this to about 5,500. The only thing that we're left with after about 5,500 to 6,000 is this little one here, which is done laterally. Now, if you do this with IMRT, you don't have to worry about the electrons and the photon junction, or the electron or the photon junction here and here, because it's all done with the computer and the MLC. These are all done with the MLC, all of this stuff, here, here, and here. And here you don't, but So all of this is done with the MLC. But with the electrons, you don't have to worry if you're doing IMRT. You don't have to worry about electrons.
The bottom one is not used by the, it's not done by the computer, the MLC?
This one?
Yeah.
Yes. Well, this one, no. And that's what I was going to mention. This is in the center of the field. The MLC comes in from the sides of
The shape.
the shape comes in from the sides. If you have something that goes down the middle, you can't do it with MLC.
So there's a
So
shape.
how would you do that? If you're treating from the front, right?
You're treating from the front.
They put an actual shape.
You put an actual block. You make a block and put it on a tray.
So how easy is it to make these blocks, to shape it like this?
You mean like this?
Yeah, so that can't be easy.
It's not too bad actually, once you know how. Basically what you have to do is, it's usually done with a film, an actual X-ray film. You put it at a certain distance. You have a pointer attached to a hot wire. You put a piece of styrofoam on it, above it, and you trace the shape that the doctor has put on the film onto or through a styrofoam block. That gives you the shape. You fill the block with molten Saraband. It goes onto a tray, and then the tray goes into the machine. That's a short and dirty version.
And then once it's cool, it's fine to use.
Pardon?
And once it's cool, it's fine to use.
Yes, but it takes a while to cool.
So what happens to those after you're done with them?
They get remold, they get
They don't need to waste them. Probably
No.
expensive.
it is expensive, yeah. So you basically take it off the tray, put it back in a pot, and it remelts and is used for somebody else. Although these days we don't use these very often. The only time we use them is for electrons. And these
So
are,
you're saying this procedure right here is not done very often anymore, the three?
not usually done very often, but
Can be.
you have to know it because somewhere along the line, somebody's probably gonna ask you to do it.
What kind of block is that? The one you just showed us?
Saraband.
I mean, is that for head and neck, that one specifically?
No, that one's for photons.
So that's just like a general block that you can use, like that's.
No,
shape and
no, that
stuff.
was made for somebody.
Oh,
That one is shaped. You see it's shaped. So that one was made for somebody and was donated to the school.
somebody's spine, that's.
No.
Okay.
That would be something like this would be something like a small chest field. Because this is the area you're treating.
It's basically taken, the MLC is taking part of this now, but for this specific treatment, you need it to block. the
That's right.
electrons,
Yeah. So anything that happens to be in the center of a field that you can't use the MLC for, because the MLC comes in from the side, you have to use a block.
yes. And we've already given the dose to the spinal cord, so it has to be shielded.
No. This one you have, in most cases, this one is done from the very beginning, the anterior one.
Okay.
Because all you're worried about is the supraclavicular and infraclavicular nodes here. You can start with the open and then put a shielding block in. It depends entirely on what the doc wants to do.
But in doing that, you would expose the spine to.
Well, you wouldn't be going any higher than 4,500 anyway.
Is that, when you say 4,500, is that lifetime or is that like one treatment?
One
Right.
treatment,
Not
one,
not one treatment, one, is that lifetime exposure of, when you say 4,500?
4,500 is the tolerance of the spinal cord in that particular area. So it is possible to treat the spine in that particular area to more. It depends on how far between the treatments are. So what I'm saying is, I would give 4,500 to the spine in that area, right? And if a patient came back 20 years later and had a problem there which we would have to retreat, which would mean retreating the spine, then it is possible to retreat that area. It is highly dangerous to retreat that area, but it is possible to do it.
So what I'm asking is for that chest area there, it would be better from the beginning to cover it, right? So you wouldn't have exposed it to anything.
But if the doctor suggests that there are nodes here that he
Okay.
has to treat,
Then you would.
then we would have to leave it open to 4,500 so we can treat that area and then put the shielding block on. Does that make sense? Okay.
So her first question was 4,500 per dose or 4,500 altogether?
4,500 is the total dose that you can give that area of the spine throughout that treatment.
Like broken up over a period of visits.
Yeah, so if we were giving 35 fractions, then 25 fractions, we'd give 4,500 centigrade. And then we would take it off cord so the cord does not get any more than 4,500.
And then you would go back and treat with electrons?
Yes, because the electrons don't reach far enough to do this, to the cord any harm. The nodes are very superficial in that area.
Now, are the electrons, is that dose a separate dose? Like, or is it built into the 45?
No, we're not treating the electrons until we reach 4,500.
Okay,
We're not starting the electrons till we reach 4,500.
okay. So is there a standard dose for electrons for the spine? Like amount of treatment?
Normally it's about, well, depending on what the physician wants, it usually is probably around 1,200 centigrade. But again, it's very much what the physician wants. He may want to stop the spine at 4,000. Therefore, we'd have to give a little more of the electrons. So it's a very much an individual thing. But what I'm giving you is the normal doses that most people would have. Okay, so now we've done that. And this is how all of the head and necks used to be done. The 3 fields. The 2 laterals and the 1 supraclavicular field. Nowadays, they're all done usually with VMAT. And everything is worked out so that the cord doesn't get as high as the rest of the fields do.
These are static fields?
No, you can do a VMAT. You can do static fields if you wish, but it's a lot easier to do it VMAT.
And that VMAT is accurate enough where it can come right off that spinal cord and still hit the nodes properly?
Yeah, because all of the calculations are done using the MLC, and they're moving the MLC in and out and getting everything done, yeah.
So that means that it's moving throughout that whole process.
Yeah,
Changing
That's
shape.
exactly it. if you watch a VMAT treatment, you'll see the MLCs moving constantly to get the actual field size done. So we don't actually have a field size for VMAT because the area is moving constantly. The patient's staying still, but the actual MLCs and the field size is moving constantly. Okay, so.
Thanks, Fred.
So let's go back to this. So the opposed laterals is what we've just decided. The supraclavicular field, we've seen. The off cord is taking it off of the spinal cord and putting an electron on there. That's what the posterior triangles are. And depending on where we're treating, your lateral, superior, inferior, anterior, and posterior. So your posterior, your anterior would be base of, superior would be base of brain. The posterior would be posterior to the bones of the spinal column. Inferior would be the junction between the lateral and the supraclavicular field. And the anterior would be the edge of the mandible. And there's the borders for the supraclavicular field. So the off cord. So beam energy. Photons, 6 MV. Electrons, depending on the depth. Laterals, 4,500. And then that takes us off cord after 4,500. Supraclavicular, we're doing 5040, 5,040 centigrade. And the total dose to the whole area, or to the tumor actually itself, is somewhere between 6,500 and 7,500. And when you think about it, what would we have for side effects? What's xerostomia? No? Somebody tell me. Xerostomia? Why don't somebody look it up? Since you've
On
all
it.
got,
I'm
what?
on it.
Dry mouth.
Dry mouth. Dry, sore mouth. That's for nasopharynx. So what does that give you? So if you have a dry mouth, what's the problem there?
Salivary glands aren't producing enough saliva.
They're making an awful lot of saliva, but the treatment is drying up. So you don't get the saliva working in the nasopharynx, which will make it difficult to do what?
Swallow.
Swallow,
Put your food down.
yeah, eat, drink.
Be a pain to breathe. You probably have to get a humidifier for your room if you live in a dry environment to help with the moisturize. You know.
Let's put it this way, you probably need a humidifier anyway, whether you live in a dry environment or not, when you're doing this. So if you have somebody who has a problem, remember, most of it is up high. It's opposite the nose, so it's not actually going down too far to the mouth. We're actually shielding the mouth. So we don't have a lot of problems with eating per se. It's just that sometimes they don't smell too well. And if you don't smell your food, are you gonna eat it? Are you gonna enjoy it?
Lose appetite.
Yeah, so for the moment, that's the only problem. So this is the effect of IMRT and VMAT. So let's go to oral. So general information. What is the difference between leukoplakia and erythroplakia? I think we've gone over this before, but anyway. Leukoplakia and erythroplakia. What's the difference?
Like that.
Which one's which?
Luca's white.
White spots, or those red spots.
Yeah, okay, so leukoplakia is the white spots. Erythroplakia is the dark spots. So dysplasia. What's dysplasia? Think back to your cellular anatomy.
I know like hip dysplasia is like when
We're
you're.
talking about dysplasia of cells.
Well, I didn't know if it'd be like similar.
Hmm?
I didn't know if it'd be like similar.
Yeah, so what is it, if I said that these cells are dysplasia, show dysplasia, what does that mean?
Abnormal growth.
Abnormal, they don't look like normal cells. So we would have a biopsy or a laser. So oral cancer, 35,000 new cases annually, 7,500 deaths. Race is, I believe, mainly white. And age is what they call midlife, which is something around 60. Who would you think would be the first person to notice either a precancerous tumor or an oral cancer? Who would be the first person to see it, apart from yourself?
Dentist or hygienist?
The dentist or hygienist. These days, the dentists are supposed to give the mouth a once-over to check for either precancerous or cancerous tumors. Has anybody been to the dentist recently and had them do that? No?
Yes.
Yes?
Where they like check, like all feel around?
Yeah, feel the neck and look inside and check around.
My sister's in the dental hygiene program, so I was her patient and they did that on.
Okay, okay. So, yeah, so that's what they're supposed to do. Whether they do it or not, that's what the dentist is supposed to do. Whether they do it or not is a different matter, but that's what they're supposed to do. So, oral cancer. Risk factors, surprisingly enough, tobacco. Any kind of tobacco. Whether it be cigarette, cigar, pipe, smokeless, chewing tobacco, snuff,
What was the age you said?
around 60-ish. So basically, any type of tobacco use, whether it, as I say, be smokeless, pipe, cigar, vaping, chewing tobacco. Worst cancer I ever saw was in a young man. Well, one of the worst ones I've seen a few, was in a young man who was 25 years old and he had stage 4 oral cancer because he'd been chewing tobacco since he was 12 or 13. And we asked him why, and he said because he was a big baseball fan. And at that point, all the big baseball guys used to chew tobacco. So he decided, good enough for them, it's good enough for me. So, and secondhand smoke. Again, alcohol, UV, irritation, as in the dentures. Remember we mentioned the dentures being loose fitting or irritating. That's something else the dentists are supposed to check for. And nutrition. And this Plummer-Vinson syndrome, which is a familial disease, or syndrome, I should say. Also, mouthwash, HPV, being immunosuppressed, lichen planus, which is a precancerous condition, and gender, male being the one that we don't want to be. Why mouthwash?
Alcohol.
Alcohol, yeah, because if you remember, if we go back, one of our risk factors is alcohol, and most of the commercial mouthwashes that we have these days has alcohol in it. So, we have several things. We have oral tongue, we have lip, we have floor of mouth, salivary gland, and gums. So let's see which one comes up first. Okay. So symptoms, sores, pain, lump, wet or red patch, which would be leukoplakia or erythroplakia, and a sore throat. That would be from the mouth. But let's go back to the lip. The lip can be treated like a skin cancer because it's sort of right there, right? Right here. What do you think might cause cancer of the lip? Oh, excuse me, what? Sorry? The sun? Yeah, okay.
Smoking, pipes, cigarettes.
Pipe. Does anybody know anybody who still smokes a pipe? Dad? Grandpa? Yeah. Have you noticed that they don't remove the pipe much? He just sits there on the side of his mouth and he talks and drinks and probably eats as well without taking the pipe out. What does that do to the lip? It irritates, right? It irritates the lip. And have you ever felt the stem of the pipe? It can get pretty hot. So you've got this hot stem of the pipe, and it sits on the lip, and believe you me, they'll eat and they'll drink. I don't think they'll ever sleep with the pipe in, but they'll do absolutely everything else. Most guys who smoke a pipe won't take it out for much. So it sits there and it rubs and it's warm and it can irritate. And that will cause a skin cancer of the lip. So how would we treat that? First you have to get the pipe away from them.
So I was about to say, take a bite out.
Surgery?
Surgery, okay. Not usually. Radiation. What type of radiation?
Superficial?
Yeah, superficial. Superficial is actually ideal for this. What other thing can you do with it? What other treatment can you give?
Topical?
Topical. In some cases, if it's very, very shallow, you can use topical. Superficial or electrons is what I was looking for. And you treat it like you would a normal skin cancer. It would be sitting there and you would have this lip here and you would treat sort of this area. You put something behind the lip to protect the teeth and the gums. And then you would go ahead and treat them. What would we put behind the teeth? Or behind the gums, excuse me. We're treating the lip. We have to protect the gums and we have to protect teeth. What would we put there?
Is that the bite block where that comes in?
No. So what protects against radiation? Pardon? Lead. Okay. So we would put a piece of lead. We would, in some cases, we cover it in wax and then just put it behind the lip. And that will protect the gums and the teeth. And we're just treating this way. So we're just treating sort of this way. And you protect top lip and something in here and protect the lip, the gums and the teeth.
Is that what you bite down on when you're at the dentist for taking x-rays, that little rectangle thing that they stick?
That's a
down
film.
and bite on? That's the actual film?
That's an actual film, yeah. I believe you maybe haven't changed much. Last time I was at the dentist and they did one, I can remember getting one of those done 40 years ago. Mind you, the technique has changed and the material, but the film is exactly the same. And she says, yeah, I know. So anyway, so let's see if we can get a hold of the lip. Okay. So most of the oral cancers are squamous cell carcinomas. You have verrucous carcinoma and salivary glands, but normally you have squamous cell carcinoma. All of the head and neck, basically, if somebody asks you what type of cancer, what type of cells in the head and neck, squamous cell. So the lip, 5 to 10% with oral, with positive nodes. Flora mouth and oral tongue, 35 to 40% present with positive nodes. So treatment, surgery. If we were doing surgery, we would do primary tumor resection for most of the oral cancer. Mandibular resection. What does that mean?
Part of your jawbone.
Yeah, taking away part of the mandible. Myzelectomy.
Top part of your
Top part of the mouth.
Yeah, so think about that. You maybe do removal of part of the mandible. You might wanna remove part of the maxilla. What does that do? Leaves you without too much. You're taking away part of the bone here and part of the bone here. And maybe the nodes as well. And Mohs microsurgery. What would we use that on? What was Mohs surgery? Where did we hear that?
Skin cancer, nose.
Layers, taking layers off.
Where would we use that though?
On the nose or the lips, I guess.
It's any kind of skin cancer, right? With the exception, possible exception of one of these skin cancers. But yeah, it would be done, if it was done at all in the oral cavity, it would be done on the lip. Because you can basically make that as a skin cancer. Neck dissection. Let's go back down to dental extraction. If we have to treat anywhere in the mouth, we would be treating the teeth. There's no way around it. You cannot shield the lip, you can shield the teeth, but everywhere else, the tongue, the buccal mucosa, anywhere, you have to treat the teeth. You cannot shield them. So they'd be sent to the dentist with, the dentist would say, or would be given instructions to deal with anything that he thinks needs help. So if you had a problem, if the patient had a problem needing extractions, for example, or fillings, then the dentist would do all that work first. Simply because if we start treating whatever area of the mouth the patient needs to be treated, we cannot stop halfway for dental surgery. Because that would alter the shape of his mouth. Think about if, for example, the patient needed all of his teeth removed. What would that do to the shape of his mouth? It would alter it quite considerably, right? So, all of that dental work has to be done before we even start planning the treatment. So that can be a matter of weeks before we can even start planning. Because the mask has to be made. The mouth bite has to be done. This is where the mouth bite comes in. So what we do with this is that we make a mouth bite, and it can be something as fancy as this. It could also be something like half a dozen tongue depressors wrapped together to give you a mouth bite. Or as one of my the physician in California used to use a wine cork. I said you may as well put it for good use, so that's what we used to use. We'd use some of these if necessary, but so. Why would we need a mouth bite? Why would we need to keep the mouth in the same position? Or maybe keep the mouth open, like that. Why do you think we need to do that?
Well, if your mouth is closed, the teeth are pretty dense to get through. Does that have anything to do with it?
No, because we've got 6 MV field, we can go through anything. Why might we need to keep the mouth open?
Maybe keep it in the same position.
Yeah. The other thing is that if we put something in the mouth, we may want to push the tongue down. Sorry, I can't do that very much. Push the tongue down in order to either keep it in the field, the treatment field, or keep it out of the treatment field. So if we're going to do floor of mouth, which would be this area, floor of mouth would be this area. So the tongue would have to be, the problem with floor of mouth is that it spreads upwards onto the tongue. So 99 times of 100, you have to treat the tongue. So in order to do that, you put something in the mouth to keep it open and push the tongue down into the field. Now, if we were treating upper, the palate, for example, then we'd want to push the tongue down again, but keep it out of the field this time. So we'd push the mouth bite in to keep the tongue down, either into the field or out of the field. Does that make sense? Okay. And that's why we use the mouth bite usually. So a neck dissection. Again, what we looked at earlier was that we're treating the neck. We're actually giving out or taking out the nodes in the neck, which can be rather a disfiguring type of thing. Now, I am just going to stop this for a minute. I have a photograph here that will show you here. Okay, so anybody know who Roger Ebert is or was? Everybody's too young.
He was, wasn't he a critic or a guy?
He was a film critic,
Right.
a movie critic. So he was diagnosed with floor of mouth cancer. So this is what he looked like. This is him before he had surgery. What they wanted to do was they found he had a floor of mouth cancer, which was down here. So what they did was they did a radical neck dissection, which means they had to take out all the nodes on both sides of his neck. And he actually lost his mandible. And this is what he looked like after. So you can see they've taken away all of the nodes. They've taken away his mandible. He has no jaw left. And this is what he was left with. He couldn't eat solid food. He had to be fed through a gastric tube, and he could barely talk. That's what an egg dissection sometimes does to people. Anyway, let's go back to where we were. And there we go. So pedicle or free flap reconstruction. Anybody know what that means? Okay, I'll tell you. So a pedicle or a free flap reconstruction is that if we do a dissection, what they will do is they'll take a flap, perhaps from the forehead, with its blood supply, and place it down here. So they'll just take it off, pull it down, park it there. And then once they've done the dissection, they'll take that flap down and put it here. So you've actually attached a flap from here all the way down to here. And once the blood supply has worked its way into this area, then they'll remove the flap from this side and just leave it on here. It's a way to make it a little less ugly, I guess.
So what do they replace this with? The section that they're doing here?
It'll heal itself. It'll heal itself, yeah. What they might do is take a piece of tissue from the leg or the arm and put it up here. I think we need a break. What do you say? 20 minutes, guys? Okay, so it's now. In most oral treatments, for example, in floor and mouth, and the same with the nasal or the pharynx, we always treat with chemo as well. So it says here neoadjuvant and palliation. What does neoadjuvant mean?
With at the same time.
That would be adjuvant, yes. So what's neoadjuvant?
Secondary,
Nope,
first.
Isn't neo supposed to be new
first.
first?
So what happens is, if you remember a little while ago, I mentioned that the chemo is always given first. So we always give the chemo first and then the radiation right after. So for example, if the patient comes in on the Monday, the chemo is given first, then it comes down for radiation. And we do that because if they're doing radiosensitizers, the chemo has to be done first so it can sensitize the cells to the radiation. So it has to be done first. And then we can do palliation. We sometimes use chemo for palliation, not very often, but we sometimes use chemo for palliation. We can also just give radiation treatment. So two agents that are most common are cisplatin and 5-FU, or 5-fluorouracil. is the correct name for that. And that would be the two normal ones. Think back, where else did we use 5FU for? Think back to last semester. Where else did we use 5-fluorouracil for? It's all gone away.
It's all fall.
It's all gone away.
I remember talking about it a lot though.
Skin cancer?
Pardon?
Skin cancer?
Occasionally we would do topical 5FU, but that's not
Maybe
what I was
breast?
thinking. Pardon?
Breast?
Nope,
Prostate?
nope. We don't do chemotherapy for prostate, remember?
I'm just throwing stuff out there.
Rectum,
Okay.
colorectal,
Close.
colorectal.
I'm like, I remember it being lower, but that's about all I can
So
remember.
colon and rectum, or colorectal is what we call it. Okay, so that is of use there.
It's like-
So lip cancers, here we go. Indications, obviously the lip. Treatment parameters, so single field electron or single field superficial. Right on here with internal shielding, remember we talked about that with the piece of lead covered usually in wax, put in between, behind the lip, so that it protects the cheek, the gums and the teeth. Depending on the size, it can go anything from 6,000 to 7,000 centigrade. Floor of mouth and tongue. So oral tongue. What part of the tongue is the oral tongue?
Part that you can see,
Pardon?
the part that you can see.
Part that you can see, okay? Actually, the part that you can move. That is the oral tongue.
Okay.
Whatever, yeah. So treatment parameters, when it says the standard head and neck, that's what they mean. That would be the two laterals and the supraclavicular field. So tongue immobilization, that's when we would use the bite block or some kind of immobilization for the tongue, whether it's pushing it down or keeping it down. Because floor of mouth, always you have to treat the tongue when you're treating floor of mouth. Those upper neck, 65 to 75,000, or 7,500, excuse me, and supraclavicular 50-40. So this area with the primary beam would get approximately somewhere between 65 and 75. This whole area would get 45. And then this little area here would get something like 55. And this one would get 50-40. Oropharynx. Treatment parameters, same as before. But you have to remember where it is. So the nasopharynx would be higher, the oropharynx would be slightly lower. And then the floor of mouth is here. And again, you notice the field, the doses, they're pretty well similar. So, larynx. It is pronounced larynx. Some people pronounce it differently.
Larynx.
Exactly, and I can't do that. I can't actually say that. So anyway, remember it is larynx.
Larynx.
You'll drive everybody nuts if you say anything else, okay? And by the time you're finished in this class, you will not say it that way either, okay?
I don't say it like that.
No.
I had a professor that said it like that, and I used to drive me crazy.
Yeah,
And
it
I'm
drives
like,
me
I
crazy.
do I just know it wrong?
Yeah,
But I don't think
Yeah.
it was wrong. I think
no,
was
it's,
right.
some people just cannot get their brain around larynx. And there was one gentleman in my class a while ago, and I just couldn't get him to say it correctly. Anyway, so divisions of the larynx. You have the glottis, the supraglottis, and the subglottis. Which is the one that has the vocal cords?
So,
Which one? Pardon?
Is the supraglottis the epiglottis? Is that the same?
Nope. The epiglottis has nothing to do with the larynx.
The epiglottis is neither one of those.
No.
Any of those.
So which one has the vocal cords?
Pharynx?
no,
What?
Subglottis.
It's either part of the glottis,
Oh.
supraglottis, or the subglottis. Somebody said it.
Subglottis.
I'm guessing the
Supraglottis.
supra.
It's actually the glottis. Because the glottis is in the middle, supraglottis is above, subglottis is below. So the glottis, that's what has the vocal cords. So, hypopharynx and larynx. 11,300 new cases. It's actually decreasing. And 60 deaths per year, approximately. Why would you think the larynx is, or the incidence is decreasing? Anybody care to take a guess?
Less people smoking?
Less people smoking?
Okay.
Okay.
You're switching to vaping. I don't know if
Yeah.
that makes much of
Yeah.
a difference, but.
Yeah, the causes of larynx cancer are usually smoking and drinking. And when a lot of people or more people are not smoking, it sort of tends to reduce the numbers. Causes unknown, risk factors. Here we go. Tobacco, alcohol, nutritional deficits, HPV, and immunosuppression. Again, as with most of the head and neck patients, the larynx patients smoke and drink. All of these patients, remember, have to have a mask made. Risk factors again, occupational exposure, which is the things like tar and chemicals and various other things. Gender, again, male. Age, around 50. Race, white. And GERD, gastroesophageal reflux disease. Why do you think that might be a risk factor?
The constant acidity from
Mm-hmm.
hitting your throat.
Yeah, because basically, as its name suggests, you have a lot of reflux. What comes up? The gastric juices. What are the gastric juices made of?
Acid.
Acid. So that can irritate a lot. So symptoms. Hoarseness. That's the main cause, that's the main symptom of laryngeal cancers. The hypopharyngeal, which is just slightly below, is sore throat, cough, pain, hoarseness, and a mass. Majority of the time when somebody comes in with laryngeal cancer, you'll hear them, their hoarseness. That's the one thing that you notice. Their voice is hoarse. So, again, squamous cell carcinoma, the majority of them. Adenocarcinomas and chondrosarcomas, but the majority of them are squamous cells, as with most of the head and necks. So, the larynx. We treat the larynx, very small fields. Is that coming from there?
Mm-hmm.
That's the MTs having fun in there. The vocal cords lack lymphatic drainage. So if we treat the larynx, all we are treating is a very small area. We do not have to treat any of the nodes because the larynx doesn't have lymph nodes. So to spread from the larynx itself, it has to go through the blood supply. It can spread through the lymphatics because it hasn't got any. And it says anatomically resistant to spread by direct extension. So in order to spread, it has to get into the blood supply. That's why a lot of times you tend to get early larynx cancers or small larynx cancers, because even the bigger ones are still in the larynx. But remember, the larynx is small. We can cover the area of the larynx with a 5 centimeter square field. It's about that size by about that size, right here. So the glottis, T1, tumor limited to vocal cords with normal mobility. T1A, tumor limited to one vocal cord. T1B, tumor involves both vocal cords. So what would that do to your voice if you had a tumor sitting on your vocal cords?
Probably couldn't talk.
You can still talk, but it would be, that's
Very
why they're
difficult.
hoarse.
Yeah.
That's why their voice changes quite a bit. Tumor, so T2, tumor extends to supraglottis and or subglottis and or with impaired vocal cord mobility. That's when the voice has a problem. If the cord mobility, the vocal cords have to be able to move
Right.
in order to make words. So if the vocal cord doesn't move, you can't really vocalize very well. So T3, still tumor limited to the larynx with vocal cord fixation. And T4, okay, tumor invades through the thyroid cartilage and or to other tissues beyond the larynx, trachea, soft tissues of the neck, including thyroid and pharynx. Then it would go to the blood supply, and therefore you very rarely get a T4 larynx spreading through the body. Usually it stays in that area. We'll get those in a minute. So, surgery. Vocal cord stripping. Sounds evil, doesn't it? What would you think vocal cord stripping means? Oh. Any ideas? Vocal cord stripping. It means that if you have a tumor on the cord, they can go in surgically and basically take it off the cord and strip it off the cord. And it can take some of the cord with it, so your voice would never be the same again, but the tumor would be gone. Cordectomy. That's an easy one. What's a cordectomy? Yeah, taking away the cords. So that would mean?
Talk.
It would be difficult to talk, yes. And then laser surgery. So that's what a lot of the singers have, is the laser surgery, because a lot of the strain goes on the larynx, right?
So when somebody says they have a nodule or whatever on their vocal cords, like a singer or something, is that usually cancer, or can that also just be a benign growth?
It can just be a benign thing, yeah. Because what happens is that if, for example, they're a singer or an actor or something that uses their voice a lot, then you can have, it gets irritated, and therefore you can get a little bit of a growth or a thickening in the, on the cord, and that would be what it is. And that's probably where the laser surgery comes in. But people like, the guy who's married to Catherine Zeta-Jones, what's his name? Douglas, had larynx cancer, and it was surgically removed. So he still has his voice, but it's not as good as it used to be. So, partial laryngectomy, total laryngectomy, pharyngectomy, neck dissection, tracheostomy, and a G-tube. So, partial and total laryngectomy. So it says standard treatment for advanced disease. So partial laryngectomy would be, okay, let's make it total laryngectomy. Take out the larynx. So he wouldn't be able to talk. This sometimes is combined with the tracheostomy. If the area, if they have a problem with breathing, then they have a tracheostomy done as well. And what does that entail? What's a tracheostomy?
Like a hole, you can breathe or something, like a breathing hole?
I can't remember what the difference is between an ostomy and an otomy. One is, I think, isn't one
Tracheotomy.
Stomy is like a hole, right? It's when
stomy
it's
is a hole, yeah. But
Yeah.
an ostomy, I
Ostomy
can't
is a
remember.
surgical hole as well.
Yeah.
Yeah,
both-
one of
the
them might have a
both-
stent put in, maybe?
Well, no, a tracheostomy or a tracheotomy, it's the same thing actually, just a different way of saying it. You basically put a tracheostomy or a tracheotomy in to help the patient breathe. And that can be either temporary or permanent. Sometimes if you have a patient who has a problem with the breathing, then they'll do a trach to help them breathe. And then once it has finished, once they have got better, then they will sew up the tracheotomy and they'll go back to normal again, hopefully. But they can, most of the time when we do a tracheotomy, oh dear, okay. Oh, here we go, sorry, I didn't know enough. When we do a tracheotomy, it's a permanent one. So what they'll do is they'll make a hole, they'll put a tracheotomy tube in, and that's how the patient breathes. Because they can't breathe further up because it's blocked. Or they can't breathe further down because it's blocked. But usually it's further up. And that's how they breathe. So you may, if you're treating a patient with either an advanced larynx cancer or a pharynx cancer, one of the pharynx cancers, then you may come across a patient with a tracheotomy tube. And sometimes they'll have an actual tube in place. Sometimes there's just a stoma, which is the hole. You can have either or. So how does it, the patient will talk, but they'll talk by putting their hand across their throat, covering the stoma, and they'll talk that way. Or they'll have what they call an artificial larynx, which is it looks very similar to a microphone, and they hold it to their throat and they'll actually talk, and you'll hear it coming out from the microphone. It takes a while to get used to what they're talking about, but it actually works very well. And some people can talk very well using what they call esophageal speech. So they bring the air from the esophagus and talk that way. There's one problem, however. If you have to treat someone with a trach, they may have a lot of phlegm in that area. So if they start to cough, where does the phlegm come from? Here. So you're leaning over them to put the mask on and you get this stuff coming out of the mouth, out of the throat. It can be rather disconcerting, shall we say. And I had a lady who, I was walking into the department one day and she was standing outside smoking through her trach. If you gotta do it, you gotta do it, I guess. I don't know. Oh yeah, very hardcore. So what's a G tube? I'm sorry, gastric tube. So why do we put those in?
Help eat, because they might not be able to.
Yeah, there's two things that they may do. Is they can do a G tube, which is a tube that goes right into the stomach, or they can do an NG tube, which goes in the nose and down again into the stomach. It's more disfiguring. Most people think if they have an NG tube in, it doesn't look as nice. Whereas the G tube, they can cover it up. There's nothing you can cover up but an NG tube.
I ask you a question. My brother has had radiation therapy for neck cancer from the human papillomavirus. But they offered him at the very beginning, they wanted him, I'm trying to figure out, do they put a port in to feed, like a feeding port, so that when you get to the point where you can't eat or something? Because he refused it.
Yeah.
And they said, you know, we really recommend, you know, you're
Yeah.
getting your neck done, we really recommend, no, I don't need it, I don't need it.
Yeah,
He was begging them.
yeah,
I mean, he got to the point where he couldn't eat
Yeah.
anything, couldn't drink
yeah.
anything.
Normally, we would suggest that they wait. These days, we would suggest that they wait and try and eat as much as they can, or as often as they can, or as much as they can. And we tell them that if they don't eat, they're gonna have either an NG tube or a G tube put in. And this is probably what was meant, they don't usually put it in to the port. That's to get blood out or to put chemo in. But it's either an NG tube or a G tube that
But
they
when he
do.
finally wanted it, he couldn't get it because it was so messed up for a year. I guess they figured, you know, you're almost done with your treatment.
Yeah.
You'd be more paid for us to try to get it in
Yeah.
there or whatever.
Well, in that case, most people would put a G
Yeah.
tube in, and that would at least help them.
Yeah.
The thing that we suggest to our patients, and this is the threat that the physicians do, is if you don't eat, we're gonna have to give you an NG tube or a G tube. So what we tell them to eat whatever they can. Things like mashed potatoes, scrambled egg, Boost, Ensure, milkshakes, whatever. We want as many calories into them as is humanly possible. And it does have a problem because think about the worst sunburn you've ever had. Think about that and then think about it inside of your throat.
Yeah, because he has a very high pain threshold.
That's-
He said it's the
Yeah,
worst thing he's ever gone through.
That's what these patients have to go through. That's why I said it's the worst. I wouldn't wish my worst enemy and a head and neck cancer. And that's the problem. So they normally start off with, well, you know, I can eat things like, you know, whatever. And then they'll go to soft foods, and then they'll go to liquids. And we used to tell our patients to go to McDonald's and get a milkshake because it has hundreds of calories. And then they'd add fruit to it and put it in the blender and drink that. But things like nothing too hot, nothing too cold, nothing too spicy. Otherwise, it hurts like the blazes going down. It hurts like the blazes going down
It took him about a year
anyway.
to be able to taste food again.
Yeah,
He's just gotten to where he's like, oh, yeah, now I remember
Yeah.
what this tastes like.
and the taste goes as well. So that's the other thing, the taste goes. Because you're treating the mouth. Therefore, you have to treat a little bit of the salivary glands. Therefore, the saliva isn't there when you want it, and the taste goes. So it's like, one of the patients used to say to us that it's like eating sawdust. And some bright spark of a student said, what does sawdust taste like? And the guy just collapsed in hysterics. He said, oh, should have said that. But anyway, there's no taste to anything. So, 5FU and cisplatin and chemoradiation. So, primary treatment for early stage glottic cancer is local irradiation. Small fields, lateral fields, one here, and 5 by 5 field approximately, right here. So basically, you would have the borders over, if you think about a 5x5 area here, think about your, surface anatomy last semester. And do you remember surface anatomy from last semester? Yeah, that's what we're looking for. So, wedges, bolus, those 65 to 70,000. That's the normal dose for stage 1 and stage 2 larynx. Wedges, why do we need the wedges? What are wedges? Do you remember what wedges were?
You're supposed to even out the distribution somehow?
Sorry?
Aren't they supposed to help even out the distribution of the beam for uneven surface?
Yeah, that's exactly. So this is a patient's neck here. So the larynx tumor is about here. So what we're going to do is we're going to do a field in like that and a field in like that. Is that going to be an even dose? Where are you going to get the most dose? Anybody?
Top part,
Here?
Yeah.
Yeah. Why?
if you're less distance between the skin and the, I mean, from the.
This is thinner than this. So what we
That's
want,
I meant.
yeah. So what we want is the same dose here as we're getting here. Does that make sense? So what we do is we put a wedge in this way. So the treatment comes along here. This part absorbs more dose than this part. And this part absorbs more dose than this part. So we get a beam coming in like this. This will even up the dose between here and here. So you get an even dose without putting any kind of bolus here. You don't want to do that because you're going to have a brisk, what they call brisk skin reaction, so we don't want to do that. Make sense? Okay. So, bolus. The only time that you would use bolus is if you had a tracheostomy right here. You put bolus probably around it, but we don't use bolus very much. We don't want to destroy the skin sparing effect. Everybody remember what skin sparing effect was? Anybody care to tell me what skin sparing effect is?
That it goes down to a certain depth, so it does not affect the surface as much. So if you put bullets on, you're adjusting how far down it's releasing the radiation effect.
Right, okay, so the 100% dose of these beams are a certain amount below the surface. So the skin does not get 100% of the dose. And if we put bolus on, then it would affect that dose. So hyperfractionation. What do you think hyperfractionation is?
What's the number of fractions?
Bunch of fractions.
More than normal,
More than normal. What's normal?
30?
I don't know.
So what's normal? How often do we treat these patients?
3 to 5 times a week.
5 times a week,
5 times a week?
usually 4 or 5 weeks, 40.
Well, no, give us a sec here. 5 times a week, how many times a day? Once. Okay. That's what we normally do, 5 days a week, one treatment per day. Hyperfractionation is more times per day.
So it just increases or decreases the entire fractionation period?
No, not necessarily.
So we're not increasing the number of fractions? The
We
numbers
are.
are staying the same, we're just keeping,
No, we are.
Okay.
You see, you have to remember that a fraction isn't a day. A fraction is a treatment. So if we say 6,500 to 7,000 centigrade, and we are giving 180 centigrade per day. Somebody who has a calculator, I forgot mine, divide 6,500 by 180 and tell me what it is
36,
approximately.
36.
36, okay. So we have 36 fractions, which in this case means 36 treatment days. Not 36 days, but 36 treatment days, because remember, we're only doing them Monday through Friday. So here that comes along hyperfractionation. In this case, we're doing 120 centigrade per fraction BID. What's BID?
That's twice a day.
Twice a day. Okay. So instead of giving 180 centigrade per day, we're giving 240 centigrade per day in 2 fractions,
Is there a standard amount of time that you normally would space those out in one day?
6 hours apart. So you can, on the head and neck patients, that's usually the patient that we do this on. It works very well.
Does it work more efficient for head and neck cancers alone, or would that work better for other cancers?
No, it just depends on the type of cancer it is and where the cancer is. So head and neck, it works well. Some lung, it works well, but apart from that, and it depends a lot on what the physician thinks he wants to do. It's very much an individual thing. So one patient may have BID, next patient may have single treatment per day. So 1,200, so that's 240. And we're giving approximately 7,440 treatments, dose. So that means a patient has to come in twice a day, for how many fractions? How many days?
31.
31
I was
days.
just gonna say, that must change the number of days that they have.
31 treatments. Remember, this is 5 days a week. And there may come a time when a patient cannot do that. They're not well enough to come in twice a day. We used to do 3 times a day, God help us. And that was 4 hours apart, so the poor patient had to come in 3 times.
For a month.
They probably just stay there all
Yeah.
day.
I just live there. Just move in.
Yeah.
I mean, it's okay if you live in an apartment across the street.
Yeah. Well, we had facilities that they could do that, they could stay. But, yeah, 6 hours apart minimum that we had to wait. So if the patient got treated at 8 o'clock, then they'd be treated when?
2 p.m.
8 a.m., yeah, 2 p.m. The problem happens if we're late. So maybe the patient doesn't get treated till 8:30. Then it would have to be minimum 6 hours, 2:30. So everybody would have to either be early or they'd have to keep waiting, because these patients have to be treated minimum 6 hours. So here is the glottis. It's actually not a bad survival. Overall, 5-year survival, remember, 85 to 95. So node negative T3 is still 65%. Node positive T3 is 50. Node negative T4 is 40. Node positive T4 is 10. So this is hypopharynx and larynx. So, and here's a supraglottic, 83, 70, 57, and 43. And subglottis, again. This, I believe, is backwards. I'm hoping it's backwards. 68 should be stage 1. Stage 4 is stage 2, should be 54, 53, 36. And here's the hypopharynx, which is very much lower than it always is. So I think we'll stop here, because I don't want to go into the rest of it, because we've got next week to do. So, any questions so far? I'll send you what we have, as far as